Hi and welcome to Physiotutors podcast episode 66 with Dr. Claire Minshull. Claire is a sports scientist, researcher, and visiting professor at Leeds Beckett University in the UK. She has published more than 30 papers, mainly on exercise and rehabilitation science, including strength and conditioning, and she also runs an educational company called Get Back to Sport. Today, we'll talk to Claire about S&C in physiotherapy. Hi, Claire. Welcome to the podcast, and thanks a lot for making time for us in your busy agenda.
Absolutely, my pleasure. Thanks so much for inviting me.
Sure. As always, I have a big list prepared. You've seen it, so I'm a bit afraid that it's going to be a huge episode, but definitely an interesting one. So let's dive right in. My first question is about your background. How did you end up teaching S&C to physios?
Yeah, that could be an entire episode, but I'll keep it very, very short. My journey in my career started and was for a long time purely in the academic arena. And I was in post, having done my PhD, enjoyed what I'd done there in terms of the research perspective and neuromuscular physiology, all translated to rehabilitation, understanding models of injury, potentially injury avoidance. That's a big topic. I was in academia full time for probably about 10 years or so, post PhD. So I've done plenty before that. And, I didn't, as good a career that is and brilliant it is for many, many people, it just didn't feel completely right for me. So I really enjoyed the research. I really enjoyed writing. I really enjoyed, some elements of the teaching, and I really enjoyed when I had the opportunity to translate that to practice. So oftentimes what can happen in academia is information stays within academia. It stays within academic journals, and it doesn't get translated to practice very well. And it took me a while to understand how, I had this entrepreneurial drive as well, but I didn't really know how I could translate what I'd done into, I suppose, that arena and kind of elements of working for myself, but also keeping the bits that are really important to me. So it took a while to understand what that was. I put on a course, a very long story short, I put on a course on strength and conditioning for therapists in an orthopaedic hospital in the UK, and me making massive assumptions that physios would know all the stuff that I knew as basic knowledge. It turns out that they didn't get taught it. So it sold out, and that was astounding for me. I'd done quite a bit of other kind of lecturing to professional symposia, and for a couple of other companies as well. But when I put on this course, it was like, okay, right, this is, and I really, really enjoyed doing it. And it's very different teaching individuals who are practitioners, who are there to, kind of learn versus perhaps in the academic environments where maybe not all subjects are everybody's cup of tea. It can be a little bit challenging at times. So it's just, I really enjoyed it. And it's absolutely my pleasure to be able to give individuals information that they make the difference. So if I can translate what I know into an environment that helps people improve their rehabilitation, the rehabilitation outcomes, design of exercise, and harnessing some of the science as well that, can accelerate that as well. That's a real pleasure for me. And that's how I guess I ended up many years ago when I first started that. That's how I ended up teaching strength and conditioning. And strength and conditioning people understand, I think, generally what that represents. I'm actually, as I said on many podcasts before, I'm a neuromuscular physiologist. But that can mean a lot of different things and sometimes nothing to people. So strength and conditioning is just kind of one element of that. And it really just boils down to, exercise, prescription, that dose response.
Okay, yeah, awesome stuff. It seems like that the issue in the UK is the same as in the Netherlands. Like Andreas and I, when we started our studies, we assumed that we would be in the gym twice a week at least, or that all of our class, they would be in the gym after the lectures, but that wasn't the case. So we were usually the only ones, with maybe one or two other exceptions. So what you kind of mentioned is like what we've seen as a problem as well. We graduated with people who didn't even know how to perform a squat. So that brings us to our next question, and this is what's your opinion on the general S&C knowledge of the average physio? I mean, I kind of mentioned how it was in our school when we graduated, and what the standard is here. What's your opinion? Because you are teaching the courses, obviously.
Yeah, and I've got the great privilege as well to travel the world teaching individuals, both directly, so you kind of in person, and also via my online programs. And I think what you're describing is common pretty much, well, certainly everywhere I've been. There are pockets which are slightly better in terms of and I don't mean better as any, kind of judgment of anyone. I mean the provision of teaching around exercise stress and adaptation. It's slightly better in some places, but generally that levelness of knowledge and lack of teaching at that first level, undergraduate level, is we're kind of suffering the same issues across the board. What I would say is, since having started the courses to now, the level of knowledge I feel like is gradually increasing. So to give an example, one of the first courses that I taught, I asked people, what's the definition of and what do we understand by muscle strength? Just a really basic one. And up until maybe even just a couple of years ago, I'd get something like 5 different answers, all defining strength in a different way. Now we see that muscular strength is better understood. So we're really understanding what that means. Some of the loading, some of the exercise stresses, how that what the input-output equation type thing is in terms of dose response. It's increasing gradually, which is exciting. But I still, there's still quite a way to go. And again, that's not a judgment of anybody at all.
Yeah. And if you look at the common mistakes that physios are making when it comes to applying S&C principles in practice, what would be, say, the top 3 that you come across?
I think something that stands out a lot is potentially underloading people, and I get where this comes from. You've got somebody in front of you who's in pain. Maybe they're older, and you just don't want to make them worse. Do no harm. I really get it. But that can, if we don't think about it from a physiologic perspective, what do we need to provide the body as a stimulus to cause the adaptation that we want? So if we want somebody to become stronger, we need those individuals, to be able to push those higher level efforts, push into difficulty and challenge against significant resistance. And I think, generally people, because they've not been taught, possibly because they've not even experienced it themselves, lack not just a knowledge, but sometimes a confidence to be able to do that. So I think, that's one thing. I think also there are significant pressures to remedy a multitude of things all at once. So they're certainly in the UK, in the NHS here, and I'm sure it's very similar across the globe. The demands on a physiotherapist or rehabilitation professional are huge. The time to be able to achieve that within a single consultation is minimal. And then also potentially related to that patient journey, might have taken weeks, if not months, to get to your door. Their expectations are significant. So there's a real pressure to do a lot in a very short period of time. And that can often mean that we do a lot of things very poorly. So if we're trying to do all things all at once, let's assume for one moment you give your patient 38 different exercises and they do them. Not that they do none, because we know that generally that probably won't happen. But if they were, for example, to concurrently train high intensity strength, high intensity muscular endurance, cardiovascular endurance, then the benefits of both would be potentially attenuated, or certainly of one, by doing lots of things all together all at once. And then you run the risk also of kind of overload and interference effect and carryover effect. So I think that's another thing, the challenge to look at, I suppose, establishing hierarchy of importance. What's most important in that rehabilitation environment, and then the third thing is really, or third thing. There's lots of things we can talk about, but another thing is how much time have you got to realistically make a difference? So if you have the opportunity to see somebody for several months, that's fantastic. If you've only got, 6 weeks with that individual, we know that, for example, eliciting a hypertrophic change or the muscle cross-sectional area, that takes a longer time than eliciting a muscle strength gain. So if you were, thinking that, assigning those rehab priorities and putting hypertrophy over muscular strength, and you've only got a short period of time, then, that might be less effective than perhaps doing it the other way around. So I think that kind of comes into, I suppose, periodization and thinking about your important outcomes and assigning almost like a period of time to that to move on to something else, all the while acknowledging what's required from that stimulus to cause the adaptation, but also the time period by which you're able to accomplish that.
It made me smile when you said underloading, because Andreas and I were giving a talk called the 5 biggest mistakes in physio practice, which we usually give at universities, and one of them is underloading.
Yeah.
So that's really what we see, and the example is like the typical old school practice where you have like a treatment bench and then maybe some elastic bands, and that's about it.
Yeah.
So
you have to really think about what is
starts with the equipment.
Yeah, well, it does, and I think actually it starts with, I'd go one step back. What is it that you need to do? What is it that you want to accomplish for that individual? If it's get them stronger, we need to load the musculature to cause that adaptation to happen. And then it becomes, an issue of perhaps logistics and an equation to solve. If you don't have the equipment, how can you still elicit a challenge that's significant enough to cause that adaptation? And if you can't do it ideally, whatever that is, then maybe you've got a considered compromise. Perhaps you do a slightly lighter resistance, but it's more important to go more towards failure if we're looking for recruitment of a fast-twitch multi-unit capacity and fibres. So yeah, I mean, it is challenging, and I think what I try and kind of teach in my courses is, before you look at the patient and worry about the I suppose clinical presentation, first and foremost, what is it that you need to change, and physiologically, what's the best way that would happen in terms of a stimulus? Then, of course, we need to think about what's the limitations, the clinical considerations that we have, and try and solve that equation such that we can deliver the most effective intervention whilst accommodating those things.
Okay, and we already touched on hypertrophy and strength. And I mean, exercise can have many benefits, but why would you say is hypertrophy or are hypertrophy and strength important for rehabilitation?
We can go on forever on this one. I think let's just look at the two things are obviously in the different. You'd want to to elicit an optimal change in muscle cross-sectional area, hypertrophy, or muscular strength. You'd want a different approach. Now, there isn't this direct relationship or perfect relationship of one-to-one. So muscular strength isn't perfectly correlated with muscle cross-sectional area. So it's not an R equals 1. That being said, larger muscles, assuming it's contractile tissue rather than kind of fat, so larger muscles composed of contractile tissue will be stronger generally than smaller muscles. But as we age, the relationship between strength and cross-sectional area changes quite significantly. and it's still in younger populations. So I suppose mature populations, it's not that perfect one, because there are other drivers that change muscular strength. Principally, first and foremost, those adaptations that you're going to make are going to be neural. It's going to include improved neural drive, synchrony of firing of motor units, recruitment of fast-twitch motor units. If you're thinking about that clinical environment, they're trying to reduce the influence of that inhibition, so disinhibition. So I think it's probably, and sorry, just to consider that rehabilitation environment as well, is often curtailed in so much as you've got a short period of time, unless you've got, a standard surgical intervention with a standard rehabilitation afterwards, which it follows many months. Then it's better, from my perspective, in my opinion, to consider this strength first approach, because we want to maximize the utility of that tissue, and we can do that in a shorter period of time versus eliciting a hypertrophic gain. Now, why is strength and or hypertrophy important? Well, strength is, that's like your fuel tank. It enables you to do stuff. And the more stuff you want to do, the more challenging it is. Generally, the more robust you need to be, the more resilient you need to be. And also conditioning strength conditions the non-contractile tissue as well over a period of time. So we really need to align rehabilitation with the intended application, or where that individual is headed. So understanding, I developed this model of conditioning efficacy, that the end point being, what are the performance demands and injury risks of that individual, where they're going back to. And that might be an athlete, but it might also be that older person who is kind of standing up out of the chair and needing to avoid a fall, or walk on unstable ground for a couple of hours with their dog, right? So, the utility of that tissue is really, really important. Strength is related to many things. And as we age, becoming dependent on others all cause mortality. So I think that having that strength first approach is important, because we often miss that as well. We can see when there's been atrophy. We can see the difference in limb girth, and we think, I should really try and rectify that first, and need to change that. And if you have enough time to elicit that morphological change, perfect, that's great. You probably will get some strength adaptation as well, but it won't be as optimal as if you kind of switched that round and focused on muscular strength adaptation first. And it really depends on who it is that you're dealing with, what their even training age, I was going to say kind of biological age, but their training age is, and what their application is. So, it's a nuanced answer, I think, but I think the most effective we could potentially be is consider the different metrics that's important. How might you want to what's the best way to intervene to change that? What's the time frame that you've got? Maybe think about that strength first approach. It's so often missed, and like you said before, often we're kind of underloading people. And then the time frame and environment that you've got to elicit that change, and where they're headed to. Yes, too. So, what is it that they need to be getting back to, or want to be getting back to doing?
Okay, let's say we have a strength goal for a certain person. So I assume our first step would be measuring strength to have a basic measurement. How would you go about that? Because in school you're taught about the Carbonen formula and how to calculate 1RM based on multiple repetitions. How do you go about that?
Again, pragmatically, what's the best way to do it? Well, the best way to do it would be to have all the dynamometry available to you, and be able to have enough time to habituate people to come and do the test, conduct the tests, all those things. And I've been really fortunate in my career. I've had all those dynamometers. I've designed them to be effective, to be sensitive to change, etc. And incidentally, that's my next course is all on dynamometry. So just going to plug that a little bit.
That,
But, we don't have that typically in clinical practice. So what can we do? Well, now, and one of the reasons for writing the course is that we've got hundreds of now handheld dynamometers and strain gauges that are being marketed to clinicians and S&C coaches to be able to obtain some of these objective markers, which is fantastic. So I'm not at all kind of poo-pooing that. But it becomes very difficult to navigate that as a clinician or somebody who's inexperienced with dynamometry. So I'd say how to assess muscular strength. If you want that objective outcome, that objective measure, then using a dynamometer, but using a dynamometer in a way that guarantees or ensures that you've got a quality measurement that's sensitive to change, that's not intruded massively by measurement error. Because most applications that people use them for, if we go into Instagram, fantastic that you're doing it, but there's loads of errors that mean that measure, if you're using that data to drive decision making, and particularly return to play, if you've got data that's unreliable and not representative of true biologic performance, you're going to make the wrong decision, and that, depending where you are, that could be quite costly. So definitely dynamometry and done well. But again, not everywhere has got dynamometry. So you then want to try and establish a test that is almost a proxy marker. So you can, you mentioned the formulae, and that's fine, but it doesn't give you a marker of strength. So if you're doing 10 repetitions and you're working out what a 1RM might be, that is not an assessment of muscular strength. That's assessment of a 10RM. And incidentally, how accurate are they? Well, they can be reasonably accurate if you give people enough chance to get familiar with resistance exercise that you're using to make those estimates. But that's not the assessment of strength. You've assessed a 10RM. So can you do something that's a little more proximal to what strength would be? So in patient populations, how often are you able to get a 1RM? Probably, through range, probably very unlikely, or it would certainly be a considerable challenge. But can you get a 5RM? So if you can't get, can you even get a 3RM if you can't get a 1RM? And that will give you just a proxy marker of change. So whilst it's not absolutely the measurement of strength, if you can't get a 1RM, can you get a 3 or a 5? And with strength going up, those things should also increase. If you don't have resistance equipment, you don't have, this gym equipment, then what can you do? And as we design more and more of these tests, the further away it comes from that actual, maximal voluntary contraction. But, if you're assuming that performance will go up commensurate with strength increases, it can give you an idea. So it might be maybe some older populations where sit to stand might be a challenge. You might want to do a 30-second sit to stand. That's not a test of strength. But if they're standing up out of the chair represents almost a maximal effort, then they're going to be, if they get stronger, they'll be able to do more. Or maybe how long it takes them to do 5. And there's some calculations and formulae you can use to, if you know the height of the individual, the height of the chair, you can even make an estimate of muscle power. So how we should be assessing it is really determined on what you've got in terms of equipment. But ultimately, the objective way would be to get that figure via dynamometry in a very well controlled and precise way.
Got it. And if we dive a little bit deeper into exercise prescription, I have prepared a couple of questions for you. When would you choose for compound exercises versus isolation exercises in rehab?
Yeah, great question. So compound, obviously using a multitude of joints and muscles, isolation, really isolating that joint or that muscle group. In MSK rehab, we've often got the remit to remedy unilateral performance, should we say. So you've often got a unilateral injury, and therefore it becomes quite important to focus on that side, that muscle group, to enhance performance, whether it be strength or, whatever metric RFD that you're looking at. So those types of exercises are, isolation exercises are fantastic to do that, because if you're to do it in a compound way, then you're, thinking that there's a potential really that you're offsetting that stimulus by taking more of it on the side that's not injured, that's weaker, less stable, whatever it is. So really, I think isolation exercises are fantastic at the kind of early stage in that rehabilitation process. Then we can move more towards compound type exercise, which means that you've then got an intermuscular coordination requirement. So whether that be within the same limb, so maybe you're doing single leg press, come from knee extension through to double limb, and that translates then more into where that individual is headed. So it's not that doing, I'm not saying that isolation exercises or a single leg knee extension is not functional at all. Getting the quads stronger is clearly going to help with function. But the way that I would view it, in that if you've certainly got that remit to remedy single limb performance, focus on that single limb initially. And then, you can start to look at introducing compound exercise as we head towards return to activities, play, etc. And they are also a great way of being able to target multiple muscle groups all at once. So if you think about a gym program where we're improving, let's say we need to focus on strength or agonist, antagonist, maybe some other muscles as well, kind of in that kinetic chain. And maybe you're doing isolation exercises to start with. That can accrue quite a lot of time. But if you then put that into a compound exercise, let's just take a squatting example, or a leg press example even, which is more stable, then you're able to target a multitude of muscle groups all at once. Therefore, your almost maintenance program becomes halved or thirds, to keep hold of that performance that you've accrued prior using isolation exercise.
Okay, yeah, great stuff. And how far into fatigue should we push patients? Do you have a general rule for that depends on irritability of the patient, or do you have a rule of thumb that can help us?
So I prefer to use the term failure rather than fatigue. And that can be construed as quite negative, but within the clinician environment and the prescriber environment, failure meaning that it's no longer possible to do anymore. Fatigue can be interpreted a multitude of different ways. Like, I want you to go to fatigue, and they might already start out going, oh God, I feel so knackered. I'm tired, I didn't sleep well last night. Oh, this feels a bit difficult, I'm fatigued. It's quite difficult to attribute an objective marker to that. It's a perception. And if you want somebody to push really bloody hard against a resistance to try and elicit a strength gain, then, I think we can be a little more precise with terminology that might help with those coaching points to be able to achieve that. So in terms of going to failure, if we just take kind of irritability out of the equation just for a moment, we're really trying to align the exercise prescription with the adaptation that we want to elicit. Now, something is better than nothing, 100%. Okay, that's the baseline. Then we can start to go, how specific can we get with our exercise prescriptions? Can we focus on muscular strength optimally? Very high load, very short duration. So you're targeting from the off. All pretty much what you want to do is recruit everything within the musculature, especially those fast twitch motor units, from the start of that set, and at the end of that set. So it's going to be maybe up to 5 repetitions in total, thereabouts. Maybe a little bit more, maybe a little bit less, but really making it very challenging, and then giving enough rest in between sets for those motor units to recover. Now, high load, low repetition being the best, if you like, for strength adaptation, optimal strength adaptation. As I said, something's better than nothing, pushing people to do novel exercise certainly will elicit strength gains as long as they're making an effort. But how much do you want to optimize that environment? If you are working at a lower intensity, so you're able to do a lot more repetitions, it becomes more important to go to failure at those lower intensity sets, because it's at the end of those sets where those fast twitch motor units and muscle fibers are recruited. So at the start, it's not very challenging. Let's say, I don't know, maybe it's, I'm making this up, but perhaps a 60% of a 1RM or 70% of a 1RM as an arbitrary figure. At the start, it's not that challenging. You can do many of those repetitions. So therefore, we don't need to recruit from everything that we have. We can probably manage that quite conservatively. But the closer we get to failure, the more motor units we need to recruit to maintain that same level of muscle force output. So therefore, at the end of those sets, it becomes a little bit more important to go towards failure or fatigue, as you put it, versus those ones that are a lot heavier. So those sets or those efforts are a lot heavier and more intense. So it really depends on what you want to, I suppose, what resource you have to, how far you need to push into that. But as a rule of thumb, the heavier sets, it becomes less, the data that is shown becomes less important to go to absolute failure versus the lighter sets. Something's better than nothing. Working really hard is great. And then if you can go heavier, that will optimize more strength adaptation. And without necessarily totally going to failure, but certainly the submaximal sets, it becomes more important. And then to address the point about irritability and pain and clinical considerations, I don't think that's an issue of going to failure or fatigue. I think that's a way of, we need to look at exercise adaptation. So is there, and again, I teach this on all of my courses, you've got the problem to solve, because you need to know the best type of exercise, the best exercise prescription. You've got people, get people to do it, right? And then not only that, you've got people that show up who are in pain, or have got maybe a brace on, or have been casted. How do you navigate around that problem? So there are a multitude of ways that you can adapt exercise to take account of many presentations that mean that as long as clinically you're happy for them to kind of train for high intensity strength, for example, then we can change the presentation of that exercise, whether it be isometric. Training at long muscle lengths is fantastic. It can confer benefits through to shorter muscle lengths, and dynamically as well, as long as it's those kind of very high intensity efforts. We don't have to work through a range. We've got closed kinetic chain, open kinetic chain, then cross-education effect, train the other side. There's so many different things that we can do that enables us to maintain the specificity of that exercise prescription, so the higher load, and accommodate the symptoms and the presentations that patient and that client is coming with before we even need to reduce that load.
Yeah, I feel like what I see in clinic, so coming back to what you just mentioned, is that a lot of colleagues struggle with adapting the exercise program to the presentation of the patient in terms of progression, regression. If a person is in pain, how can I change the exercise a little bit, be it isometric, be it different angles? I think this is where a lot of struggle is in the physio world. I don't know if you see that in your
all
courses.
all the time, yeah. And again, I'm not judging or portioning blame here. There's a load of stuff that needs to get done in that appointment. But if you can take just a breath before you start and think about what is it, you go for the a couple of things that you can change effectively. The hierarchy of importance. What's most important? How can I set my programming up, my environment up successfully to achieve that? And then look at the presentation of that individual. If closed kinetic chain is provocative, don't do closed kinetic chain exercise. So I've just been this weekend teaching with Claire Patella. So we teach a PFJ course, and some of the great strategies that we can give for kind of getting individuals stronger are, thinking about open kinetic chain, closed kinetic chain, commensurate with the experience of patellofemoral joint pain. So open kinetic chain presentation of pain is a slightly different angle than it is on closed kinetic chain exercise. Yeah. So it gives two different options straight away, depending on where those individuals through the range are experiencing pain. Straight away, you've got two options. So yeah, just it's, as I said, it can be quite challenging to think about these things, but just understanding that challenging the musculature to work hard will cause it to adapt. And we've got lots of different strategies. We can even just do eccentric work. So eccentric work preferentially recruits from that fast twitch motor unit pool. Even if we're not going to failure under eccentric conditions, we can do those faster efforts. So we're maybe not provoking that pain response as much. Give enough time between repetitions so it's not being amplified. All sorts of different ways we can think about presentation of exercise before we need to drop that intensity and lose our specificity.
Yeah. A lot of people focus on strength and hypertrophy, but I think what is often forgotten is rate of force development. What is it? How do we measure it? And how do we train it?
A great topic. Something that is, I'm a big fan of this because it's about the delivery of the muscular force that you've trained or you have. So I've done so many assessments of this index. It's by comparison to strength, it's a highly variable index. It's much more variable than attaining the maximal voluntary contraction or the peak of that maximal voluntary contraction, because it requires a lot more mastery by the individual who's doing the test, and also that testing environment needs to be really precise. So what is it? The rate of force development. And I'm pleased that it's now becoming more popular in the term within the rehabilitation field. We've been testing this in physiology, neuromuscular physiology for decades, probably even longer than that actually. But it's the slope of that force time curve. How quickly can you deliver strength? How quickly can you produce force is a better description. And it's often used interchangeably with power, muscle power, but it's not the same thing. So if you think about an assessment of muscle power, maybe you're doing something like a vertical jump or a hop for distance or throwing a projectile. Now, you absolutely need good rate of force development to elicit a good power performance. But let's take an example of a vertical jump. You see, you assess them on time 1, and they come back on time 2, and they jump 20% higher, but they've lost 5 kilos of weight. But what you're trying to do is influence the contractile properties of the musculature. And that's rate of force development. The assessment of muscle power is probably the closest you're going to get to be able to assess that. So you improve muscular contractile properties. You should, depending on what test you use, you should be able to, as I said, depends what test you use, detect that on a muscular power type of test. Some handheld dynamometers will give you an estimate of RFD. That's often 0 to peak. So I know the Lafayette does. I know some, I think the new Val device, Dynamo Plus has got that. Certainly some force frames, some other, you can even get velocity of movement with kind of accelerometry. Now, in terms of RFD, 0 to peak will give you a marker of rapidity of force production. But it's not often we produce maximal force within any kind of given setting, injury avoidance setting or sport performance setting. So when we measure it in the lab, we typically either split that curve up into 50 millisecond epochs, so 0 to 50, to 100, to 150, to maybe even 200. We don't typically go much further than that. So that 200, it'll take around about 300 milliseconds, so a third of a second, to produce your maximal force in a maximal voluntary contraction under isometric conditions. Now, most injuries don't take that long. They take much, much less time than a third of a second. So those earlier force time characteristics are probably more important than the later force time characteristics. Okay. So yes, you can get an assessment of RFD. It might go from 0 to peak, but you'll be missing some of that data and that information on the earlier, the influence relative performance of the earlier part of that force time curve, which might be, depending what setting you're in, really quite important. And that being said as well, on my power courses, so making sense of muscle power, we look at the contractile properties, and you can be specific to your intervention. So that earliest part of that force time curve is influenced preferentially or most by the neural characteristics. After about 75, 80 milliseconds, it's influenced more by the morphological characteristics. So that's where you're talking about hypertrophy, the size of musculature, the maximal strength as well. So you can be even more specific, super specific about which elements that you want to improve, where the deficits are. We've now got enough data to do meta-analyses on RFD within ACL populations, which is great. And that shows deficits akin to, or interlimb symmetry deficits, should we say, that akin to strength deficits that we've seen, maybe even more, and showing that early and late phase as well as influence. So it's really, really important to think about difficult to measure, the single way to differentiate between strength, optimizing for strength adaptation and optimizing for the intrinsic contractile properties, being fast, is the intent. Oh. The intent to do something explosively. And that can be resistance-based exercise, which you can modulate the load for, which is something that you cannot do as well as bodyweight type exercises, which are plyometric. So you can go faster with plyometric exercise, but you can't go as heavy as resistance-based exercise. Mm. But yeah, I could keep talking for ages on this, but I'll just pause that. But the key difference is the intent to be explosive.
Yeah. So instead of moving a weight with whatever speed, you want to move a weight, probably a bit of a lighter weight, as fast as possible, right? That's more or less it. If you see a deficit in the athlete and you want to train for that variable.
Absolutely. Yeah, that's a very, very nice way to put it.
Yeah, I'm trying to put it as easy as possible. And moving on, because I have so many topics, and I think we could talk for hours. But I have a couple of points where I want your opinion on. You quickly mentioned the repeated, or let's say, first of all, the cross education effect. What is it, and why, and how does it work? What's the idea behind it?
So the cross-education effect is shows a huge potential within MSK populations where you have unilateral injuries or unilateral presentations. It refers to a strength gain observed in an untrained limb caused by strength training the opposite limb. So if you've not heard of that before, it sounds very peculiar. We've known about this since... or not me personally, 1894, because if I was around in 1894, I should probably be selling skin cream or something, shouldn't I? So we've known about it since 1894. What does it mean? If I was to strength train my right biceps and I get 50 newtons of improvement in strength in my right bicep, under the most optimal situation, you might see a 50% improvement in my left. So that would be 25 newtons for free in an untrained limb. And wow, that's astounding. And as I said, 50% is kind of the maximum that's ever been reported, but it's been reported we know about this. We've known about this for decades within sport performance and training. But only recently is it being translated, or has it been translated into, God knows why, orthopedic and MSK populations. The stroke guys are much, much further on. Now, the neuro guys are absolutely much further on, but us in orthopedics are kind of taking a while to catch up. So within rehab and kind of injury settings, what we're actually most probably concerned with is attenuation of loss. And it's called strength sparing. So imagine somebody who has an injury, they maybe are casted, or they maybe undergo surgery. That in of itself causes a deficit in strength performance. So we did a study in an ACL population and or ACL reconstructed population, should I say. What you expect to see around about 10 weeks following the ACL reconstruction, which is probably about the first time any forward-thinking orthopedic surgeon will let you test maximal quad strength in an open kinetic way. That's a different conversation. But you usually see around about a 30% deficit pre-surgery to post-surgery in the quads. Now, we randomly allocated patients to a cross-education program or a upper limb flexibility program. So something that they did that was extra, they got extra attention, but would convey no influence on lower limb performance. And everybody did the same rehab for the ACL reconstruction. It's just that one group did some strength training on the non-operative leg. That was 3 to 5 rep max, leg press, knee extension, hamstring curls. And so what did we see? Kind of quickly coming to the results, that indeed we saw that strength deficit in the control group or the placebo group. It was 32% loss in quad strength at 10 weeks post. The group that did the 8 weeks worth of cross-education training, we almost half it. It was 16%. So for just a little bit of extra time and no more money, really, we were able to attenuate that strength loss at that 10-week mark. Now, we've got data that shows that can happen in the first really good clinical study was in with clinical populations was in upper limb fragility fracture patients. So distal radius fracture and attenuated loss associated with the injury and casting. Then we have this massive gap of about 20 years or so, 10 years or something like that. Then we've got 1 or 2 studies in the ACL, of which ours is one. And then I know there are 1 or 2 groups now working to extend that research in ACL. But for me, where the biggest opportunities lay are probably things like total knee replacement, hip replacement, things like that, where there's huge deficits, and in those individuals that are load compromised as well. But yeah, huge potential utility there. And that's one, where your individual patient client is load compromised or is completely restricted, then for me, it's a no-brainer to give that a shot. There's some blogs on my site about it and a masterclass if people want to know a bit more about the dose and response and how much, but it's got to be strength training in intensity, high intensity, 3 to 5 rep max stuff, or eccentric. We think probably because of the fast twitch involvement. Hypertrophy programs don't work, neither do or the intense programs at 8 to 12 intensity, or muscular endurance programs don't work either.
Okay. And is there any simple explanation like that you would give to a patient how this works?
No. So the way to describe it is a neural adaptation. So there's absolutely no morphological change. You will not see a change in cross-sectional area in the untrained limb. Why it works, we still don't really know exactly. There's probably a spillover effect in the cortex. There is probably something happening at the spinal cord level. And what's really interesting is that we've just seen this elicited by means of electrical stimulation. So Prof. Maffoletti's group just last year published a study whereby they stimulated by means of electrical stimulation the non-operative leg for a period of time, and saw that strength sparing effect in the operative leg. Now, think for a moment about that. That involves no conscious involvement of the individual to perform a muscle contraction. So it adds another layer of intrigue and uncertainty as why it's happening. But we still think it's probably fast twitch recruitment related, because electrical stimulation as delivered by those, so it probably won't work with, I'd hazard a guess, with the things like your Compex and commercially available ones, because you're unable to change stimulation frequency up to those higher levels. So fast twitch units are firing around about 50 hertz. I'm unsure that you'd get that from, well, certainly in the commercially available units I've seen, you can't change stimulation frequency. So we still think it's probably something to do with the fast twitch units and recruitment of those, which has got some sort of spillover effect into the other muscle, or the other homologous muscle. But exactly why, we're still a little bit, still working on that. Or people much cleverer than I are working on that.
And moving on, I'm going to skip one or two questions because I feel like I'm opening a can of worms, and then we're going to take a totally different direction. I think we can all agree that exercise is important for patients, but the challenge is often to convince them to do the exercises. Do you have any tips to create buy-in?
Oh, wow. So everything that I've learned about buy-in has come from the amazing Serena Simmons. She is a psychologist, and she's the psychologist for our joint approach program. It's another thing that I do, which is management of knee osteoarthritis by multidisciplinary program that's online. So imagine the challenge to not only get people to buy in who are novel to exercise, but it's online as well. And our involvement has meant that we had 0 people drop out, which is phenomenal. If you look at the landscape for those types of exercise interventions. So she runs courses for clinicians on buy-in, behaviour change in particular. And I'd highly recommend you go look at Serena Simmons' work. The key thing, there are so many things, but the thing that I am able to translate by osmosis, by having learned from her, is first and foremost, understand why somebody is there. So what is their why? And so they understand their why. So why, what are you here for? My doctor told me, not good enough. You're not going to get that intrinsic buy-in. It doesn't mean enough to them. So the more work you can do around that, and it might be that first consultation, you do very little exercise. So I'd like to say all the fantastic results that we've got from the joint approach program is down to my amazing exercise prescriptions. But the reality of that is, if we don't get buy-in and we don't actually understand, there's a whole psychology of feeling benefit as well. There's another layer of stuff. But if we didn't get buy-in, just chuck that in the bin, right? So it's super, super important. So those first consultation, with your patient or your client, you might not do all that much. You need to, that sounds very didactic. It would be of benefit to try and understand why that person is there and elicit that intrinsic why. And if it's, I want to be able to play with my grandkids, well, exactly what can you not do that you want to be able to do? And what does that mean? Oh. And that shared decision making as well. So what do you think might be really important to help you get there? And that, kind of motivational interviewing type scenario involving them and empowering them. The more of that you can do, in my experience, as I said, I'm not a psychologist. I've learned this of some amazing people. The more of that you can do, the better the buy-in. And I always say, if on those rare occasions where I do now manage to see individuals, I honestly don't care what somebody does in their first session. I just want them to come back to a second. Because if you can get that, and like you were saying, that buy-in, you've got a better chance of changing and tweaking that exercise prescription to get to where, or somewhere close to where you want to be. So if you want to improve muscular strength, or you want to improve proprioceptive acuity, but that individual is very anxious, they have never exercised before, they're in significant pain, they're catastrophizing, all those things, it's kind of pointless talking to them about that, isn't it? So, there's, understand, I guess, as I say, kind of understanding their why, trying to drill down into that to make it an intrinsic thing, and getting almost quite granular with that reasoning, and then involving them in that decision making is a very, very tiny I suppose, comment on a big topic there, but it's, as I said earlier, you've got the hardest job, because you've got to do that as well. So you've got to be a psychologist.
Yeah, that's what makes our work interesting as well. Challenging, but also interesting. I have two more questions that I would like to ask you, Claire. And the first one is, there's a lot of emerging technology in strength training and in the physio world as well. I'm looking at body vibration, BFR, muscle stimulation. Is there anything that jumps out that you feel like this is something that is really maybe the future of rehab, or that people should have in their practice?
So all of those things that you've mentioned, for me, are great adjuncts. I don't think we have one technology that is going to replace the benefits of doing the work yourselves. And each one of those, kind of technologies have got their own relative merits. So take BFR for one. That has huge potential efficacy with load compromised populations. It means you can work the musculature at a much lower level than for typical strength type training, and you can get a great adaptation in muscular strength and hypertrophic change. Fantastic with the right there's some inclusion exclusion criteria that you need to adhere to, but it's of huge potential use. And I think that's, I teach on this because I think it's really useful. It will not replace, in my mind, under most circumstances, the need for doing resistance training proper. So in athletes, definitely not. In those other populations, I would try and counsel them to get to be able to change to normal type traditional resistance-based training, but it can provide that nice scaffold to do that, particularly whilst they're load compromised. It might induce quite a bit of DOMS. You might need to kind of progressively introduce it, but yeah, it's got great evidence for that. Whole body vibration. I love talking about this. I've got a whole course on this. I collaborate with a colleague. Whole body vibration education is the website, because again, this is a great adjunct. Now, if we look at how it's conveyed and spoken about in the, I suppose the social media domain, and it doesn't help that we've got these devices on Amazon that are like, I don't know, £30, $50 that literally shake your cellulite off. I mean, I really get why the skepticism, because that's just ridiculous, right? But again, these technologies have existed for a long while. So, whole body vibration was used and is still used by NASA to help attenuate muscle and bone loss in environments of microgravity. So for those individuals, so there's absolutely shedfuls of papers within kind of neuro populations, within orthopedic populations, within athletes now, looking at whole body vibration that shows, depending on the application, potential efficacy there of what? Of enhancing muscular performance. But just like we can have this dose response for resistance-based training, we can manipulate frequency to change the stimulus and the response. Again, these stupid devices, platforms that are plastic, and you can't manipulate frequency. You've got maybe high and low, and what the hell does that do? It's ridiculous. But vibrational frequency at 12 hertz will elicit something different to something that's 30 hertz. Those plates that go up and down, so a bit like the power plates, are often less tolerated, and you need much more higher intensity vibrational frequency to elicit similar effects to those ones that are side oscillating for several different reasons. And actually those side oscillating ones are much more tolerable. It's less perturbing, should we say. But again, that can involve, that can elicit, again, great adaptations and nice scaffold to tradition-based training, or it might be some of these populations are unable to do that because maybe the neuro populations, and that might be their mode of training that keeps them a little bit more or maintains that higher level of functioning that otherwise wouldn't be possible necessarily to obtain. And again, electrical stimulation, we can keep rolling them out, can't we? Again, done in the right way, I think is, again, in the right environment, a great adjunct to rehab. So from a strength adaptation, that it was, way back when I started my PhD, I won't say when that was. It's not 1894. We were, so Lynn Slider Mackler's group and others were talking about electrical stimulation, which was great. But also there was this dialogue around we shouldn't be using electrical stimulation in ACL populations or other populations because the musculature becomes reliant on that as an external stimulus, take it away, and then you lose the benefits. But actually a more nuanced approach where we can overlay that on top of voluntary muscle efforts, whether it's that start of kind of firing up the faster motor units, whether even we use it with BFR, and we can start to, again, accelerate those rehabilitation outcomes or indeed accrual of muscular strength or attenuation of loss. So again, electrical stimulation can be really beneficial, again, in the right kind of population. Done, again, thinking about intensity and dose. You don't just want to whack a arbitrary stimulus through the musculature over somewhere roughly over the quads. The more precise we can be, the better the effects are likely to be.
Yeah, it's probably the same story with all adjunct technologies. I mean, we have the same discussion with manual therapy. If you use it as an adjunct, if you know what you're doing, if there's clinical reasoning behind it, then why not? As long as it doesn't become the main therapy and it's applied without good clinical reasoning. Probably the same with the tools we talked about just now as well.
Yeah, I'd agree. Yeah.
Okay, Claire, I'm looking a bit at the time, and we always ask, is there anything that we haven't touched upon that you would like to add to the podcast? I mean, I think I had 4 more questions to ask you, but then we're going to explode the podcast.
There's 3 podcasts in here.
Yeah, definitely. But I probably should have been more specific and not too general about S&C with my questions. But is there anything that we haven't touched on that you feel like this is really something important and this is something you would like to add?
I think we've covered quite a lot of ground. I'm happy to come back if you want to speak more specifically on things. No, I don't think so. I think it's a nice overview of, maybe if there's one thing, people might understand strength and conditioning as just applicable to athletes, and it's about lifting really heavy stuff. For me, strength and conditioning, it's about understanding strength, whether that be muscular strength or maybe even thinking about the strength or the tolerance of tissues. And conditioning is the stimulus to apply to cause that adaptation, whether that be a muscular adaptation, a non-contractile kind of adaptation. And it's applicable to all populations. So, don't be afraid of it and think about it. It's basically exercise prescription, exercise design. It just sounds better, right? Strength and conditioning. So I think, don't be afraid of it. We've covered a lot of topics that I would class within that arena. And I suppose explore it a little bit more and try to think about that in your practice a bit.
Yeah, I think it's great that you have so much material on your website and courses to help us therapists to better apply all of those principles. I think there's a great need for it. So it's good that we have people like you out there in the field and on the social media channels to help with that.
That's my pleasure. I love doing this. I love talking to everyone that's interested that will listen.
Hey, and Claire, if people want to reach out to you, where can they find you?
Okay, so as you mentioned, I have a website, so that's getbacktosport.com. On there, there's loads of blogs and lots and lots of courses and shorter masterclasses. I'm on Twitter or X at Claire _Minshull. and on Instagram at Get Back to Sport, some other social media channels as well. But that's principally where you can find me.
All right. So coming to an end, and I would like to thank you for your time and for your knowledge, Claire. It was a pleasure to have you.
Absolutely, my pleasure. The time's flown by.
Yes, definitely. And also to all of the listeners out there, as always, thanks a lot for listening to episode. And to access the transcript and additional resources, make sure to download our new and free Physiotutors app and benefit from more useful physio content. And if you enjoyed this episode, hit the subscribe button or follow us on podcast or our podcast on Spotify or Apple Podcast, and consider leaving a review if you really enjoyed it. And with this being said, this was Kai for Physiotutors. Until next time, bye.